Welcome to our second part of our two-part presentation, Melanoma Update, with nurse practitioner Natalie Mandolfo. Natalie received her undergraduate degree from Nebraska Methodist College in 1995 and her family nurse practitioner degree in 2000 from the University of Nebraska. Natalie has written many publications as well as presented at many professional conferences. She was also involved in several breast cancer research studies. Not only is Natalie involved in her professional organizations, she's very active in her community service. In 2013, she received her 40 Under Nursing Leadership Award presented by Nebraska Action Coalition. Welcome, Natalie, and thank you for being with us today.
Thank you very much. I welcome everybody to this webinar, and thank you so much for joining me. Today we're going to talk about melanoma. So the title of the presentation is Melanoma Update. The objectives will be to describe, hopefully, after you complete this online learning activity, you'll be able to describe how treatment decisions are made for patients with melanoma, discuss advances in treatment for patients with melanoma, and identify expected side effects of systemic therapy. Melanoma, as you know, the incidence is on the rise. The incidence has been rising over the past 4 decades. Risk factors are sun exposure, patients that have multiple nevi or moles, patients that are on immunosuppressive medications or have an underlying diagnosis of immunocompromised state, patients that have pigmentary characteristics, family and personal history of melanoma, and also environmental exposures. Melanoma is a leading cause of death from skin cancer. In 2013, it's estimated that over 76,000 people will be diagnosed with melanoma, and unfortunately, almost 9,500 deaths will occur from the disease. So after a patient's diagnosed with melanoma, they see an oncologist, and the oncologist will help to determine the treatment plan based on the patient's overall health, their extent of disease, what stage of melanoma they have, the characteristics of their tumor type, any existing comorbidities, and also their performance status. So we're going to take a few moments to talk about the stages of melanoma, and the system groups patients into categories of, well, the tumor rather into categories, the tumor size, which would be the T, and then the presence or absence of regional lymph nodes, which would be N, or any distant metastasis, or M. And then patients are divided into 4 stages. And so for the first part, the T would be the size of the tumor. So it's a T1 tumor if it's less than 1 millimeter thick, and then it further classifies on the right side of the screen, A and B, with ulceration or without ulceration. And then for T2 would be larger or a thicker degree, so 1.01 to 2 millimeter thickness, again with or without ulceration. T3 would be 2.0 to 4 millimeters in thickness, and then T4 would be greater than 4 millimeters in thickness. The nodal status is very important for prognosis, and for patients that have 1 node that has positive for melanoma, they're classified as an N1. For patients that have 2 to 3 nodes, that would be classified as an N2. And for patients that have greater than 4 nodes metastasized with their melanoma, those patients are classified as N3. The M staging refers to metastatic disease, and if a patient has distant skin, subcutaneous, or nodal mets, they're M1A. If patients have diagnosis of melanoma that is spread to the lung, then it's an M1B. Or if it's gone to any other visceral organs, like the liver or any distant organs, then it's M1C. It's also important to note that serum LDH is also an important factor and is included in the melanoma staging. And you can see that on the right side of the screen. So when you put all that together, the T, N, and M staging, we get the pathologic staging. And so it's stage 1 through 4. And you can see here on the slide that it really does depend on the thickness of the tumor, whether or not there's nodal involvement, which would be N1A. Down here, it would be stage 3A. And then also with stage 4 would be any T, any N, and any distant metastasis, or even dermal metastasis with an M1. It's really important to emphasize that early detection is key to survival. For patients that have earlier stage 1 and 2 melanoma, their survival rates exceed those of the patients compared to patients that have stage 3 and 4 melanoma. You can see that on the slide. The outlook for stage 4 is better also if the spread is only to distant parts of the skin rather than to other organs, and if the blood levels of the LDH are normal. So let's just talk for a minute how the guidelines that we're going to review today are developed. Oncology practices throughout the country work with the National Comprehensive Cancer Network Guidelines, or NCCN guidelines. And there's different categories of evidence for not only just the workup of a newly diagnosed patient with melanoma, but also on what treatment would be most appropriate for that patient based on categories of evidence. And you can see on this slide that there are 3 categories of evidence. Category 1 is the best. It's really a uniform consensus that the intervention is appropriate. And then category 2A and 2B get to be a point where there is enough information that intervention is appropriate, but yet there might be a little bit of not as high as category 1, where it's a uniform consensus. And category 3 is that there may be major disagreements within the panel on the guidelines working group team. But yet there is still some evidence that it may be appropriate, but still a significant amount of disagreement. So let's just go through the guidelines for treatment of early stage 1B and stage 2 melanoma. For these patients, imaging is important, and so CT scans, PET scans, and MRI would be done to evaluate specific symptoms if the patient was experiencing. Sentinel lymph node biopsy or a wide excision with a sentinel lymph node biopsy. If the sentinel lymph node was negative and the patient is stage 1B or 2A, those patients are offered clinical trial or observation. For patients that have stage 2B or 2C, again, patients are offered clinical trial or observation or interferon alpha. If the patient has sentinel lymph node positive disease, then we'll go to stage 3 workup and primary treatment. So baseline imaging for staging, and then patients will be offered a clinical trial or a lymph node dissection, and then clinical trial or observation or interferon alpha, and again, that's category 2B, so a little bit lower level of evidence to suggest that. A fine needle aspirate is preferred if feasible, or a lymph node biopsy if a patient has clinically positive nodes. Again, baseline imaging is recommended for staging, which would include CT scans, PET scan, and then a wide excision of the primary tumor plus category lymph node dissection. Patients again offered clinical trial or observation or interferon alpha, or consideration of radiation therapy to the nodal basin if multiple nodes were involved or macroscopic extranodal extension was noted. So for patients that have distant metastasis that yet is limited, so therefore resectable, the options then for treatment would be to resect that MET and then treat with a clinical trial or observation, or to go ahead and observe or start systemic therapy, then repeat the scans at periodic intervals. If the scans were negative for other disease, then go ahead and resect, and then if there was no evidence of disease upon resection, offer that patient clinical trial or observation. If the scans were positive for other disease, treat as disseminated metastasis. And so disseminated metastasis is unresectable, and the classifications for treatment are stratified out without brain metastasis or with brain metastasis. So patients that do not have brain metastasis or spread of the melanoma to their brain, those patients would then be recommended to proceed with systemic therapy or a clinical trial and or palliative resection and or radiation therapy for symptoms. If a patient has brain metastasis, it's recommended to consider resection and or radiation therapy for patients with these brain metastases, and then proceed with systemic therapy or clinical trial or palliative resection or radiation therapy. So what are the systemic therapy options for advanced or metastatic melanoma? The NCCN guidelines offer preferred regimens, and there are several. I'm going to take the immunotherapy first. So there's ipilimumab, and then there's high-dose interleukin-2 on the slide. The other agents listed on the slide are dabrafenib and dabrafenib, or clinical trial. And you'll see that clinical trial is mentioned quite a bit throughout the presentation because there are a lot of clinical trials being offered right now for melanoma because the advances are being made at such a rapid rate. And years ago, we really had very few effective treatments for melanoma. And so it's always been a recommendation that if we have a patient that has melanoma that's metastatic, to really offer them the clinical trial so that we can offer them the best benefit. Just in the last couple of years, we've had some major advances with the approval of these medications here listed on the screen, the ipilimumab, dabrafenib, dabrafenib, and that's really changed the whole landscape of how we treat melanoma. Other active regimens, trebatinib, dacarbazine, which is a systemic chemotherapy, temozolomide, imatinib, if the patient has a c-KIT mutated tumor, again, dacarbazine or temozolomide-based combination chemotherapy with biochemotherapy, albumin-bound paclitaxel, and then paclitaxel plus carboplatin. There have been many advances in the treatment of melanoma. As we talk about the different treatments of melanoma and the different drugs recently approved for the treatment of melanoma, it's important to note there are some common toxicity criteria that I'll refer to with a grading system. And so when a drug is approved, the FDA classifies the side effect profile and also announces that, and it's printed on the prescribing information. And each side effect is given a grade for how serious it is so that healthcare providers and the patients can know exactly what to expect when they take the medication. So the general guidelines are if it's a grade 1 or mild symptom, or if it's grade 2 or moderate, meaning intervention might be indicated, but it's still not limiting the patient too much. Grade 3 would be severe or medically significant, but not immediately life-threatening. Grade 4 toxicities are life-threatening consequences where urgent intervention is indicated, and grade 5 would be death. So let's take SYLATRON, or peginterferon alpha 2b. This was approved about a year and a half ago. It's indicated for the adjuvant treatment of melanoma, so those patients not metastatic but in the adjuvant treatment of melanoma with microscopic or gross nodal involvement within 84 days of a definitive surgical resection, including complete lymphadenectomy. It's contraindicated for patients that have a history of anaphylaxis to peginterferon alpha 2b or interferon alpha 2b, or patients that have autoimmune hepatitis, or those patients that have hepatic decompensation, or a child's class B or C. It should be permanently discontinued in patients that have severe worsening signs and symptoms of depression, psychosis, or encephalopathy. It's dosed sub-Q, self-injectable once a week. The dose is 6 micrograms per kilogram per week for 8 doses, then followed by 3 micrograms per kilogram a week for up to 5 years. Pre-medications should be acetaminophen or Tylenol, 500 to 1,000 milligrams, 30 minutes prior to the first dose, and then as needed. The efficacy data was reported after 1,256 patients with surgically resected stage 3 melanoma were randomized to receive SYLATRON weekly injections, and these patients the dosage was adjusted to maintain a good performance status of 0 to 1. So if the patient was experiencing too many side effects and were getting too fatigued, the dose was actually adjusted. The primary endpoint was relapse-free survival, which is the time from randomization to the earliest date of any relapse, whether that's local, regional, in transit, or distant, or death from any cause. The median relapse-free survival was 34.8 months for patients that received SYLATRON versus 25.5 months for those that were elected to have observation or randomized to have observation, which is no treatment and close follow-up. The most common adverse reactions in patients treated with SYLATRON versus observation were fatigue at 94% versus 41%, increased ALT and AST, so liver enzymes, 77%, pyrexia or fever, 75% versus 9%, headache, 70%, anorexia, myalgia, nausea, chills, and then also injection site reaction were reported. The most common serious adverse reactions in patients treated with SYLATRON were fatigue, increased liver function, and pyrexia. So dose modifications were if the patient developed an absolute neutrophil count, or ANC, of less than 0.5, platelet count of less than 50,000, ECOG performance got worse, over a 2, so greater than 2, or if they had a non-hematologic toxicity like fatigue or depression, very common, greater than grade 3, then the drug was held. And then it would be resumed when those toxicities had recovered. SYLATRON was permanently discontinued if persistent or worsening severe neuropsychiatric disorder was noted, a grade 4 non-hematologic toxicity occurred, or inability to tolerate the dose of 1 microgram per kilogram per week, or if the patient had new or worsening retinopathy. And so on this slide you can just see the various dose modifications needed, that when the patient is taking the medication, if they were to experience toxicities requiring dose modifications, here's what it might look like. The patient might start, obviously, with a 6 microgram per kilogram per week dose, but based on the modifications or their adverse reactions to the medication, there are first, second, and third modifications recommended. So in the pivotal study, 94 patients, or 16%, did not continue on to the 3 microgram per kilogram week dosing which was recommended. Patients who continued on SYLATRON after the initial 8 doses received 3 microgram per kilogram a week for a median duration of treatment of 14.3 months. Approximately half of the patients underwent dose reductions and 70% required dose delays. So immunotherapy historically has been the mainstay for treatment of melanoma. High-dose interleukin-2 was the first treatment to influence the natural history of metastatic melanoma, and patients started receiving this in the 1980s. Immunotherapy prolongs survival for treatment of metastatic disease compared to chemotherapy, and it may result in cure in a small fraction of patients. For the adjuvant treatment, high-dose interferon A, or intron A, and then pegylated interferon B, or SYLATRON, which we just talked about, are types of immunotherapy for the treatment of melanoma. In the metastatic setting, we have high-dose IL-2, or interleukin-2, also called Proleukin, and ipilimumab, or Yervoy. Immunotherapy has been demonstrated to result in long-term responses, not immediate, in few patients with metastatic melanoma. So for immunotherapy, high-dose IL-2 is known to have severe toxicities, which can limit its application to carefully selected patients treated at experienced centers. We're going to talk about 2 types of immunotherapy during this presentation: Proleukin, or aldesleukin, manufactured by Prometheus, and ipilimumab, or Yervoy, which is an anti-CTLA-4 monoclonal antibody manufactured by Bristol Squibb. And also targeted therapy, Zelboraf, or vemurafenib, which is a BRAF inhibition manufactured by Genentech. We'll also talk about cytotoxic chemotherapy. They're single agent or combination, not been shown to improve overall survival in patients with advanced melanoma. The response rates typically are less than 20%, with median response duration of only 4 to 6 months. It was previously widely used prior to the development of ipilimumab and targeted therapies, and it does not have an established role in patients that have metastatic melanoma. Radiation therapy is also part of the treatment armamentarium for metastatic melanoma. It has a palliative role for symptomatic localized areas of disease, and also stereotactic radiosurgery may be used for patients with brain metastasis. Surgical metastasectomy can also be performed for patients that have one or very limited number of metastases, and it may have an important role in eradicating residual disease for patients who have a good response to immunotherapy. This would be used if a patient has an isolated liver metastasis or an area of spread of the melanoma that could be taken out without causing a lot of risks from the surgical procedure. So let's talk about immunotherapy for metastatic disease. And we'll start with ipilimumab, or Yervoy. It was approved in March of 2011. It's a monoclonal antibody that targets CTLA-4, creating an immune reaction against the tumor. CTLA-4 is believed to contribute to slowing down or turning off the body's immune system, affecting the ability to fight off cancerous cells. It may work by allowing the body's immune system to recognize, target, and attack cells in melanoma tumors. And it significantly increases median overall survival in both previously treated patients with metastatic or unresectable melanoma. Prolonged responses have been observed similar to those prolonged responses seen with high-dose IL-2. The safety and efficacy was established in a single international study of over 600 patients with melanoma. These patients were previously treated with other FDA-approved treatments and had failed to respond or progressed. All of them had metastatic disease that could not be resected, and they were randomly assigned to receive either Yervoy plus experimental tumor vaccine, which is GP100, Yervoy alone, or vaccine alone. And the results showed that patients that received Yervoy plus vaccine or Yervoy alone lived an average of 10 months, while those who received only the vaccine lived an average of 6.5 months. The responses may develop slowly, and patients may have a transient worsening of disease before disease stabilizes or tumor regresses. Prior treatment with IL-2 did not preclude a benefit from subsequent treatment with ipilimumab. It's dosed at 3 milligrams per kilogram IV over 90 minutes every 3 weeks for a total of 4 doses. It's to be permanently discontinued if any severe adverse reaction occurred. Side effect profile is here on the slide, with the most common is fatigue. Many patients also developed fever, some pruritus, rash, dermatitis, nausea, diarrhea, decreased appetite, vomiting, constipation, abdominal pain, anemia, cough, dyspnea, colitis, enterocolitis, and intestinal perforation was just luckily 1%. The side effects are very immune-mediated. In fact, there's a U.S. boxed warning that severe and fatal immune-mediated adverse effects due to T-cell activation and proliferation may occur. While any organ system may be involved, common severe effects include dermatitis, endocrine disorder, enterocolitis, hepatitis, and neuropathy. Reactions generally occur during treatment, although some reactions have occurred weeks to months after treatment discontinuation. It's to be discontinued permanently and initiate high-dose corticosteroid for those patients that have severe immune-mediated reactions. It's important to evaluate liver function and thyroid function tests at baseline and prior to each dose, and to assess signs for toxicity at baseline and prior to each dose. Uncommon immune-mediated adverse effects reported include hemolytic anemia, iritis, meningitis, nephritis, pericarditis, pneumonitis, and uveitis. Initiate prednisone for severe reactions. Another immunotherapy compound would be Proleukin or aldesleukin. And this was first approved, interleukin-2, was first approved in 1992, and it remains the initial immune-based therapy for those without significant comorbidity. It's part of a family of proteins called cytokines. Immune system cells naturally make a small amount of interleukin, and aldesleukin is a synthetic version of IL-2. IL-2 given to patients can result in prolonged duration of response and even associated with cure in some cases. Ipilimumab is an alternative when IL-2 is not available or appropriate for metastatic disease. Prolonged responses have been observed after ipilimumab, and it appears to be similar to those prolonged responses seen with high-dose IL-2. Ipilimumab can be used sequentially after IL-2 in some cases, and administration of high-dose IL-2 after ipilimumab may incur additional toxicities, and little information is available on its efficacy. Proleukin is shown to possess the biological activities of human native interleukin-2. The safety and efficacy was studied in a series of single and multi-center historically controlled studies enrolling a total of 525 patients with metastatic renal cell cancer or melanoma. Patients had good performance status and normal organ function, and the studies excluded patients that had brain metastasis, active infections, organ allografts, and diseases requiring steroid treatment. Metastatic melanoma, the studies that were regarding metastatic melanoma comprised 270 patients treated with a single agent Proleukin in 8 clinical studies at 22 institutions. A median of 18 of the 28 scheduled doses of Proleukin were given during the first course of therapy. The objective response seen in 43 or 16% of patients was 6% with a complete response. Now these are patients that have metastatic disease, so if we can get a 6% complete response, that's really, really great, because these patients could be cured from an otherwise thought to be an incurable situation. And 10% had partial response. And the responses were seen in both visceral and non-visceral sites, so the lung, liver, lymph nodes, soft tissue, adrenal, and subcutaneous lesions. It was also observed in individual bulky lesions and large cumulative tumor burden. Here you can just see the difference of the CRs, which is complete response, the PRs, partial response, and then together the partial plus complete responders at 16%. And look at how on the right hand of the screen, the right side of the screen, the complete responses, the duration of those lasted 59 plus months. Proleukin is contraindicated in patients that have a known hypersensitivity to interleukin-2 or any component of Proleukin formulation, patients that have an abnormal cardiac stress test, abnormal pulmonary function test, or those patients that have organ allografts. It's contraindicated in patients who have had the following drug-related toxicities while receiving an earlier course of therapy: sustained ventricular tachycardia, cardiac arrhythmias not controlled or unresponsive to management, chest pain with EKG changes consistent with angina or MI, or cardiac tamponade. Also those patients that have had to require intubation greater than 72 hours, renal failure requiring dialysis greater than 72 hours, coma, repetitive or difficult to control seizures, bowel ischemia, perforation, GA bleeding requiring surgery. It's dosed IV 600,000 units per kilogram every 8 hours for a maximum of 14 doses. It can be repeated after 9 days for a total of 28 doses per course. And patients are retreated if tumor shrinkage is observed and if there are no contraindications at least 7 weeks after hospital discharge date. Here are some of the toxicities that are seen. Patients can develop hypotension, 71%, and there you can see that 3% of patients had grade 4 toxicity, which is life-threatening. 28% of patients experienced peripheral edema, 23% with tachycardia, 15% edema, 13% vasodilation, 12% SVT, and 11% other cardiovascular disorder, which includes blood pressure changes, heart failure, and EKG changes. Other toxicities commonly seen are central nervous system toxicities, including chills, some confusion, fever, malaise, somnolence, anxiety, pain, and dizziness. Dermatologic toxicities have also occurred and are quite common. 42% occur or develop a rash, 24% with pruritus, and 18% with exfoliative dermatitis. 12% of patients experience acidosis, 1% grade 4. Hypomagnesemia and hypocalcemia were also reported. Gastrointestinal side effects are also common, with 67% of patients experiencing diarrhea, 2% at grade 4, nausea and vomiting, stomatitis, anorexia, some patients, 16%, actually experienced weight gain, and 11% abdominal pain. Hematologic toxicities were also noted, with 37% of patients experiencing thrombocytopenia, 29% anemia, 16% leukopenia, Hyperbilirubinemia was also observed in 40% of the patients. 2% were grade 4 toxicities or life-threatening. AST was also seen in 23%. Neuromuscular and skeletal adverse effects were also noted with weakness, 23%. Renal toxicity with oliguria, 63% and 6% grade 4. Elevated creatinine was observed in 33% of the patients with 1% grade 4. Respiratory compromise can occur. 43% of patients experienced dyspnea, 1% was grade 4, life-threatening. Other lung disorders, including pulmonary congestion, rales, and rhonchi, were observed in 24% of the patients. 11% of patients experienced another acute respiratory disorder, which would be either acute respiratory distress syndrome, infiltrates, or pulmonary changes. And then 11% of patients also experienced cough. Miscellaneous adverse events that were noticed were antibody formation in a fair number of patients, 66 to 74% of patients, and infection was noted in 13% of the patients with 1% grade 4. So there are a lot of warnings and precautions with Proleukin, and as with all immunotherapy, these adverse events are frequent and sometimes can be fatal. There are U.S. boxed warnings regarding capillary leak syndrome, as high-dose Proleukin has been associated with capillary leak syndrome, characterized by vascular tone loss and extravasation of the plasma proteins and fluid into extravascular space. This can result in significant hypotension and reduced organ perfusion, which may be severe and can result in death. CNS toxicity is also a U.S. boxed warning. Treatment will be withheld for patients that develop moderate to severe lethargy or somnolence, and continued treatment could result in coma. Infections also can occur. Impaired neutrophil function is associated with treatment, and patients are at risk for disseminated infection and central line-related gram-positive infections. Treating pre-existing bacterial infection appropriately is critical prior to treatment of Proleukin. Other disease-related concerns would be autoimmune or inflammatory disorders, so it should be used in caution with those patients. Also, cardiopulmonary disease is a U.S. boxed warning, and treatment should be restricted to patients with normal cardiac and pulmonary function as defined by stress tests and formal pulmonary function testing. Extreme caution should be used in patients with prior cardiac or pulmonary disease. Patients should be evaluated and treated for central nervous system metastasis and have a negative scan prior to treatment, because new neurological symptoms have been reported in patients without pre-existing CNS metastasis. These symptoms generally improve upon discontinuation. However, cases with permanent damage have been reported. It is known that it may also impair hepatic function, so concomitant hepatotoxic agents may increase the risk of hepatotoxicity. Renal function can also be compromised, so patients must have a serum creatinine of less than or equal to 1.5 milligram per deciliter prior to treatment. And it's very important that Proleukin should be administered under the supervision of an experienced cancer chemotherapy physician in a facility with cardiopulmonary or intensive specialists and intensive care facilities available. So now let's move on to some targeted therapy. Zelboraf, or vemurafenib. It was approved in August of 2011 after results of an international trial of 675 patients with metastatic melanoma were randomized to receive Zelboraf versus dacarbazine, which is chemotherapy. All patients had BRAF V600E mutation and had not received prior chemotherapy. The median survival time for those treated with dacarbazine was 8 months. The median survival time for those treated with Zelboraf had not been reached at the time of FDA approval. 77% were living at that time. BRAF inhibitor, approximately 1/2 of melanomas have this V600 BRAF mutation that activates the MAPK pathway. BRAF inhibition produces rapid tumor regression in the majority of patients with V600 mutant melanoma, including those with extensive tumor burden and disease-related symptoms. It significantly increases overall survival in patients with metastatic melanoma and these mutations. Zelboraf continued treatment is necessary to maintain response. The majority of the patients progress within 6 to 12 months. It's dosed orally, 960 milligrams twice a day, taken approximately 12 hours apart with or without a meal, not to be crushed or chewed. Based on side effects, there are dose modification criteria that can be found in the prescribing information. Common side effects include peripheral edema, 17 to 23%, fatigue and headache, nausea, diarrhea, vomiting, decreased appetite, constipation, and altered taste. It's very important that patients that are on Zelboraf have a routine or frequent skin examination by a dermatologist because it's quite common to experience the development of a papilloma or even a squamous cell skin cancer while on treatment. Also, arthralgias are quite common, 53 to 67%, myalgias, bone pain, back pain, musculoskeletal pain, and weakness. Also, respiratory side effects can occur with cough, 8 to 12%, and then fever, 17 to 19%. Skin rash is common, 27 to 52%, with 7 to 8% grade 3 toxicity. Skin photosensitivity is very common, 33 to 49%, with 3% grade 3 toxicity. And so when we prescribe Zelboraf, it's very important to provide great patient education and letting them know that all sun exposure, even just walking from the house out to the mailbox, requires sunscreen for protection, as well as a wide-brim hat and clothing that would cover most of the skin. Alopecia has also been reported, pruritus or itching, hyperkeratosis, actinic keratosis, seborrheic keratosis, pilaris, macular papular rash, xeroderma, and sunburn have also been observed. So dermatologic toxicity is very common and very important one to note with the treatment of melanoma with the Zelboraf. There have even been some case reports of Stevens-Johnson syndrome and toxic epidermal necrolysis. So it's to be discontinued permanently for severe dermatologic toxicity. However, most of the dermatologic toxicity can be managed with dose reduction and careful patient education. It is also known that it increases liver function tests, and it's important to monitor the liver function test at baseline and monthly during therapy, and then as clinically necessary. Patients may require dose reduction, therapy interruption, or discontinuation based on toxicity. Severe hypersensitivity, including anaphylaxis, has been reported with the use and following reinitiation of treatment. So if a patient has a hypersensitivity reaction that's severe, the treatment should be discontinued. Again, malignancies have been observed with cutaneous squamous cell carcinomas, and other skin cancers have been reported, even melanoma, at a higher rate in patients receiving dabrafenib compared to the control group. Ocular toxicity is also important to note, as uveitis cases have been reported, so patients should be monitored for signs and symptoms. Symptoms can typically be managed with corticosteroid and mydriatic eye drops. Cases of blurred vision, iritis, photophobia, and single case of retinal vein occlusion has also been reported from the clinical trials. Photosensitivity is also common, ranging from mild to severe. So it's important to advise patients to avoid sun exposure, to wear protective clothing, and use effective sunscreen and lip balm. Dose modifications are recommended for those patients as well that do experience a greater than 10% to 30% of body surface area erythema. QT prolongation has been observed, and so it's important that patients have normal electrolytes, so checking their calcium, magnesium, and potassium at baseline and with dose adjustments, monitoring the EKG at baseline, 15 days after initiation, and then monthly for 3 months, and then every 3 months thereafter. And it's not to be initiated if the baseline QT interval is greater than 500 milliseconds. There are dose modifications for this as well, as you can see on the screen, and it's not to be recommended in patients that have electrolyte abnormalities that are not correctable. There are a lot of drug interactions with Zelboraf. It's a substrate of CYP3A4. Therefore, co-administration of a strong CYP3A4 inhibitor or inducer may alter the concentration of the drug. It's recommended that we avoid co-administration of Zelboraf with a strong CYP3A4 inhibitor or strong inducers, and those drugs are listed on the slide. CYP1A2 substrates, Zelboraf may increase the concentration of these drugs, so it's important that we avoid co-administration, but if it cannot be avoided, to monitor closely for toxicities and consider a dose reduction of the concomitant CYP1A2 substrates. So it's important to know the mutation status of the tumor. All patients should have their tumors assayed for the presence or absence of a driver mutation at the V600 site of BRAF. The presence of such mutation determines whether a patient is likely to respond to BRAF inhibitor. BRAF inhibitors do not have a role in the treatment of patients without this mutation. When available, genotyping for other driver mutations like KIT or NRAS should also be considered, because it may determine whether that patient may be eligible for an alternative research protocol and may provide useful prognostic information. Patients with other mutations in the MAPK pathway, such as NRAS, also appear to be more likely to respond to high-dose IL-2. So in July of this year, another BRAF inhibitor was approved by the FDA, and it's called Tafinlar, or dabrafenib. It is dosed orally, just like Zelboraf is, dosed slightly different with 150 milligrams twice a day, taken at least 1 hour before, at least 2 hours after a meal. Again, it's a BRAF inhibitor, approved for the treatment of those patients that have a mutation of the BRAF V600E gene. Most common adverse reactions, very similar to the Zelboraf that we just talked about, with hyperkeratosis, headache, pyrexia, arthralgias, hyperkeratosis, papilloma, alopecia, and plantar palmar erythrodysesthesia syndrome. And here you can see on the slide very similar side effect profile to what we just talked about with our other BRAF inhibitor. There are warnings and precautions with this drug as well. New primary cutaneous malignancies. Again, important to have a good communication with the dermatologist with careful follow-up. Patients should be evaluated every 2 months while on therapy and for up to 6 months following discontinuation of the drug. Tumor promotion in BRAF wild-type melanoma is increased, and so it can occur with BRAF inhibitors. Serious febrile drug reactions can also occur. Hyperglycemia is also noted with this drug, where it was not noted on the last previously discussed BRAF inhibitor. So it's important to monitor serum glucose levels. Uveitis and iritis is also noted. Closely monitoring for hemolytic anemia in patients that have G6PD deficiency or glucose 6-phosphate dehydrogenase deficiency. It's also known to cause fetal harm, so it's not advised to give to women that may have potential for pregnancy. So the efficacy data is here on the slide. So it was studied in over 250 patients that had a BRAF V600E mutation, unresectable or metastatic melanoma. They had no prior BRAF or MEK inhibitor use. It was dosed 150 milligrams twice daily as monotherapy until disease progression or unacceptable toxicity. The median duration on treatment was 4.9 months for patients treated with the Tafinlar and 2.8 months for patients that received dacarbazine or chemotherapy. The median duration of follow-up prior to initiation of an alternative treatment in the Tafinlar arm was 5.1 months, and in the dacarbazine arm was 3.5 months. 44% of the patients crossed over from the dacarbazine arm at the time of their disease progression and received Tafinlar. And the results showed a statistically significant improvement and an increase in the progression-free survival in patients treated with Tafinlar. The objective responses were 52% in those patients that received Tafinlar versus just 17% in those patients that received dacarbazine chemotherapy. 3% of patients actually had a complete response, and then 48% of patients treated had a partial response versus just 17% of patients receiving dacarbazine had a partial response. No patients receiving chemotherapy had a complete response. So that leads us to the most recent, again, another recent targeted therapy, Mekinist. It's a MEK inhibitor, also called trametinib. It was approved the same day as the most recent BRAF inhibitor was approved. Both drugs are manufactured by GlaxoSmithKline, and they were both approved in July of this year. It's a MEK inhibitor, this Mekinist, and what that is it's mitogen-activated extracellular signal regulated kinase 1, or MEK1 and MEK2 activation, and of MEK1 and MEK2 kinase activity. MEK proteins are upstream regulators of the extracellular signal-related kinase, ERK, pathway, which promotes cellular proliferation, thereby promoting tumor spread. BRAF mutations result in constitutive activation of this BRAF pathway, and this leads to MEK1 and MEK2. So trametinib inhibits the BRAF V600 mutation positive melanoma cell growth in vitro and in vivo, and thereby this will slow down tumor growth and slow down cellular proliferation. It's approved for treatment of patients that have metastatic melanoma that expresses BRAF V600E or V600K gene mutation. It's dosed oral. The recommended dose is 2 milligrams once a day, taken at least 1 hour before, or at least 2 hours after a meal. It was studied in 322 patients with metastatic or unresectable melanoma that had BRAF mutation. Patients were randomized to receive either Mekinist or chemotherapy with dacarbazine or paclitaxel. The objective response was remarkable, with 22% of patients receiving Mekinist had an objective response versus just 8% of patients receiving chemotherapy. 2% of patients receiving Mekinist had a complete response versus 0 for those receiving chemotherapy. And 20% of patients had a partial response, or a PR, versus 8% respectively. Those who took Mekinist had a delay in their tumor growth or progression-free survival advantage that was 3.3 months longer than those on chemotherapy. Patients who previously received Tafinlar or other BRAF inhibitors did not appear to benefit from Mekinist. So the most common adverse reactions occurring in greater than 10% of the patients are listed here on the slide. 50% of patients developed rash, 8% were grade 3 or 4, so they required intervention. Dermatitis, acneiform, 19%. Dry skin, pruritus, so itching, 2% grade 3 or 4 toxicity there. Paronychia, 43% of patients experienced diarrhea, 15% of patients with stomatitis, with 2% grade 3 or 4, abdominal pain at 13%, lymphedema at 32%, hypertension 15%, and of note 12% was grade 3 or 4, so very important to watch blood pressure control while on Mekinist. And hemorrhage 13%, less than 1%, however, were grade 3 or 4. So there are some important warnings and precautions. Cardiomyopathy can occur, so cardiac events such as heart failure, left ventricular dysfunction, or decreased left ventricular ejection fraction were observed in clinical trials. It's important to assess the LVEF by echocardiogram or MUTATION scan prior to therapy initiation, again 1 month later, and then 2 to 3 months intervals while on therapy. Cardiac dysfunction may require treatment interruption, dosage reduction, or even discontinuation of therapy. Such measures resulted in resolution of cardiomyopathy in some patients. Dermatologic toxicity is noted again with this agent. most commonly observed in the trametinib-treated patients, some patients required hospitalization for severe toxicity or for secondary skin infections. The median time to onset and resolution of skin toxicity was about 16 days and 48 days respectively. So it's important to monitor for dermatologic toxicities, signs and symptoms of secondary infections, and dose reduce or discontinue therapy if needed. Ocular complications have also been reported with retinal pigment epithelial detachments and retinal vein occlusion, so promptly referring patients for ophthalmological evaluations if the visual disturbances occur, and interrupt or discontinue therapy may be required. And it is known to cause potential fetal harm, so not to administer to patients that have the potential for pregnancy, or if it is a premenopausal woman, it's important that she have contraception or some form of birth control. Pulmonary toxicity is also noted with interstitial lung disease and pneumonitis being observed in clinical trials. The median time to initial presentation was 160 days, so it could occur anytime, a couple months to even a couple years after being on Mekinist. Monitor for new or progressive pulmonary symptoms. Again, it may require therapy interruption or permanent discontinuation. So let's talk, now that we know what drugs are out there and available for melanoma, the sequence of therapy in treatment of metastatic disease. So if a patient has limited disease to one or a very limited number of sites, that patient will be evaluated by a surgical oncologist to determine whether complete resection of all the metastatic disease is feasible as an initial form of treatment. And then if so, complete resection of the metastatic disease has been seen with prolonged survival in some cases. So it seems to have a therapeutic benefit if we can resect the metastatic sites. Patients initially are not candidates for metastacectomy and who have a good response to immunotherapy, high-dose IL-2 or ipilimumab, should be reevaluated after completion of their immunotherapy to determine whether they may be now candidates for such surgery. When metastacectomy is not an option, so those patients with asymptomatic or minimally symptomatic patients with a normal serum LDH and metastatic disease limited to the skin, subcutaneous tissues, distant lymph nodes, or lung tend to have a better prognosis and relatively slower progressive disease. In this setting, immunotherapy is generally preferred regardless of the BRAF mutation status of the tumor. And this is because we talked about the potential for cure with immunotherapy that we just don't have with the BRAF inhibitors or the MEK inhibitors at this point. So immunotherapy, if a patient can tolerate it, really is the best treatment to obtain that cure in that subset of patients. Patients with bulky disease, other visceral metastasis, patients that have elevated serum LDH or poor performance status, tend to progress rapidly and have a shorter overall survival. If they're negative for BRAF mutation, generally these patients are candidates for ipilimumab, which is immunotherapy, and this can prolong overall survival. Clinical trial participation or chemotherapy options when the patient has progressive disease is recommended. For patients that have brain metastasis, which is very common in melanoma, an MRI of the brain is indicated if the patient has symptoms. And if they have symptomatic central nervous system metastasis, they may require therapeutic intervention, such as radiation therapy or gamma knife surgery. So what is the best treatment? Well, really, it just depends on the patient characteristics. Targeted therapy has not been compared with immunotherapy in randomized trials. The appropriate choice and sequence of treatment is based upon the patient's extent of disease, molecular characteristics of the tumor, BRAF mutation status, if it's a BRAF mutated tumor or not, and then very importantly, the patient performance status and comorbidities. Follow-up after treatment is based on the presence of new symptoms, and careful follow-up is required during and after treatment. The NCCN guidelines offer recommendations. Typically, there's a CT of the chest, abdomen, and pelvis every 3 months for the first 2 years, along with an MRI of the head every 6 months. CT and MRI can be repeated every 6 months during year 3 and then annually through year 5. And after year 5, chest x-rays This is for our adjuvant patients that have stage 1 through 3 follow-up recommendations. So in summary, primary systemic therapy options for metastatic melanoma are immunotherapy and targeted therapy. Targeted therapy has not been compared to immunotherapy in randomized clinical trials. Treatment decisions are based, again, on the patient's extent of disease, their characteristics, and their performance status and other comorbidities. Metastasectomy, so surgical excision of the metastatic sites, is possible for patients that have disease that are limited to one or a very limited number of sites, associated with prolonged survival in some cases. Systemic therapy for those patients not candidates for metastasectomy. The V600 BRAF mutation patients should be offered immunotherapy first, preferred over chemotherapy, so high-dose IL-2 or ipilimumab. Targeted therapy is not indicated for patients without that V600E mutation, or now, actually, we have the other targeted therapy, which is the MEK inhibitor. High-dose IL-2 is reserved for those good performance status patients who have access to appropriate specialized programs. Ipilimumab is recommended when IL-2 is not available or appropriate, and it can be used sequentially after IL-2 in some patients. Poor performance status or untreated brain metastasis, if not candidates for IL-2, then ipilimumab is preferred over chemotherapy. Looking for clinical trials or cytotoxic chemotherapy for those patients whose disease can no longer be controlled with immunotherapy. And I'll just pause for a moment on that one, just to really emphasize the importance of looking for a clinical trial for those patients, because cytotoxic chemotherapy has really not been shown to be that effective for patients that have metastatic melanoma. We still use it, but we'd much rather offer them a more targeted therapy or more of an immune-mediated type of therapy. The V600 BRAF mutation and poor performance status patients, it is recommended targeted therapy over immunotherapy. And then immunotherapy may be an option for second-line therapy when patients progress after targeted therapy. It's very important that we choose our patients selectively and very appropriately, because the side effects of the immunotherapy can be fatal. So we want to have patients that have good family support, good social support, and obviously we want to have a good performance status with other very minimal comorbidities, with no cardiac history, no history of any neurological problems, because immunotherapy, although it can really be the best chance of cure for our patients, can also be fatal if they have an underlying comorbidity. We want to have the healthiest patients to be able to offer that to give them the chance of cure that high-dose IL-2 can achieve for them. Proleukin, or aldesleukin, should be administered at an experienced center and by experienced physicians because of those toxicities. And so it's really, really important when we're choosing those patients, and whether they're being referred from rural parts of the Midwest, that they go to a center that has an experienced physician and ICU available to administer this medication. Side effect management is essential in keeping patients on therapy to maximize efficacy of therapy or immunotherapy, as well as targeted therapy. So with that, I want to just leave you with a positive note that we all should be aware and know the A, B, C, D, and E's of skin cancer, not only just to ourselves, but then promoting that awareness to others. And if anybody has any questions, my email is at the bottom of the slide, nmandolfo@nebraskacancer.com. Be happy to answer any questions that you might have as you went through the slide deck on your own, at your own convenience. And thank you very much.
Thank you, Natalie, and thank you for joining us today.